Thank you, Rena. I really appreciate it. Can everybody hear me? So this is actually a requirement by the University of Toronto when anybody goes anywhere. I'm not imaginative enough or smart enough to figure out how to make any money off of what I do. So I have absolutely no conflicts of interest. In full disclosure, I'm American and moved to Canada back last April. So regarding our move to Canada, some people, including my 8-year-old son Apollo, have openly questioned the motives behind the move. He came up and said, "Papa, is this Toronto because of job or because of Trump?" So I gave this a lot of thought, and I decided, because I'm so interested in narrative, I decided to kind of frame this in a heroic narrative. So I told him that we were part of the vanguard to establish the beachhead of the flight of anti-Trumpistas for the states. So he started believing that, but then he became very skeptical when I told him that we would be greeted at the border by Justin Trudeau, who he thinks is really cool, as well as the newest host of the Refugee Apprentice, Barack Obama, who he thinks is even cooler. But he still believes in Santa Claus, but he didn't believe my full story. So in terms of doctors and patients, one of my interests in terms of patient-centered or person-centered care really stems from the disjunction in communication between these two groups. George Bernard Shaw once said, "I do not know a single thoughtful and well-informed person who does not feel that the tragedy of illness at present is that it delivers you helplessly into the hands of a profession which you deeply mistrust." So communication between physicians and patients oftentimes achieves miscommunication of biblical proportion. Doctors and patients see something from the same thing, but from completely different perspectives oftentimes. That which ails somebody, that which causes suffering, is seen by doctors and patients completely differently. Oftentimes, physicians and healthcare providers tend to see it as a disease-based model. I think most of you are familiar with this. The medical conceptualization of the process based on theories of pathophysiology. In contrast, patients oftentimes will describe what happens to them as an illness. It is the subjective experience of feeling the way they feel. This is important because even the vocabulary is different. Okay, the vocabulary of disease tends to be heavy in terminology from Latin and Greek. We tend to use a lot of numbers and statistics. Illness is a very human vocabulary. Discomfort, pain, loss, disorientation. So two very different vocabularies, two very different perspectives, focused on exactly the same thing. So this is no wonder why we have so many difficulties understanding each other. So the goals of this talk are to explore the meanings of patient-centered care from a variety of different perspectives, evidence-based, philosophical, ethical, and humanistic. Oh, by the way, I was mentioning that my laptop is actually Canadian and it uses English as in like Queen's English spelling correction. So it's weird giving talks on patient-centered care up in Canada because I have to change everything. And then I came back down here and last night I realized that it was all Canadian spelling. So I went to change it back. There will be mistakes in this, so I apologize. So number two, to explore the role of dialogue and reflection in ways in which person-centered care may be learned and taught. And number three, to take steps to understand how person-centered care may be taught at the coalface of education, in particular in clinical environments. So words, we exist by words. What I do in terms of my own scholarship oftentimes is to take certain words and to put them under a critical lens and to try to understand how we use them. Because a lot of these terms, patient-centered care, person-centered care, diversity, cultural competency, reflection, learner-centered care, learner-centered education, a lot of these, we throw them around haphazardly without really defining what we mean. So for me, a lot of what I do, for instance, like with cultural competency, is to take things and pick it apart and to try to understand it through a critical lens. So in terms of words, terminology, there are terms patient-centered care, there's patient and family-centered care, there's person-centered care, and there's relationship-centered care. And depending on whom you talk to, they'll use different terms. So for instance, relationship-centered care is oftentimes used among psychiatrists because they're really interested in the relationship between the care provider and the patient. I personally prefer person-centered care, in part because the emphasis is actually on the individual. And people are not just patients, they're people who happen to be ill. So there are different definitions. The working definition that we're using up in Toronto, we've launched this huge educational initiative in the Department of Medicine on person-centered care. Our working definition is this one: recognizing and being accountable to the patient as a moral being with agency, a life story in a social context, attending to the care of the individual as well as the structures and processes organizing that care, including equity and diversity. So it's a little bit different than you normally hear, but what it is capturing this idea of agency, that we are working with people who have a moral basis and are responsible for their actions, and we need to be accountable to them. So there are many challenges in terms of patient-centered or person-centered care. One of them is this idea of science. Science is developing at such a rapid pace that it oftentimes escapes our notice, or oftentimes can actually run us over in the process. The whole business of healthcare, the commoditization of healthcare, the patient as client, okay, we oftentimes talk about the ideal patient experience and things like this. And this is a way of actually turning something which in many ways is a very sacred activity into really a commercial exchange. Obviously time. Anybody who's in clinic who has to deal with somebody's loss of a spouse, loss of a job, depression, major life transitions, and has to do it within a 15-minute follow-up period, understands the problems with time. The ubiquity of the electronic medical record. Do you folks use Epic? You use Epic? Okay. So my wife worked at Northwestern for many years. They were using Epic there. I lured her back to Michigan. They established Epic at Michigan. We moved to Toronto, and of course, the only hospital in Toronto that's using it is Women's College Hospital, where we are. She's actually happy with it. I can't stand it. Yeah. Right? And the problem is that what happens now is that the interaction between myself and the patient is mediated by a computer screen. The way they did it at Michigan when they set up the rooms was they had this computer screen here and the desk here and the patient back here. So if you worked, you turned your back to the patient. So then there are so many people who complained that they changed things around and they reformat it to more patient-centered care. So now the screen would be here and the patient would be there. So occasionally you'd have to turn around and just to make sure they were upright, right? Okay. The other issue, and I think it's a challenge, is this problem of where's the beef. Now, anybody who is over 45 in this room might remember this commercial. This is back in the 80s, I think, and it was from Burger King. There are three ladies sitting in front of a huge bun with a little patty, and and the whole point is that Burger King has bigger burgers, and this little lady is screaming on the phone, "Where's the beef? Where's the beef?" So this is actually the where's the beef question in medical education is where is the evidence that patient-centered care works, right? I mean, we're evidence-based, so there should be evidence that this actually makes sense. There have been a number of studies that have come out to look at this. This is one of them. This is by Hojat and colleagues from Jefferson Medical College, published a number of years ago in Academic Medicine. It's a correlation study of basically 900 people over 3 years, followed by 29 family docs. They used the Jefferson Empathy Scale. Are people familiar with this? Okay, so it's a scale that actually supposedly grades people according to how empathic they are. And they grouped the physicians prospectively into either high, moderate, or low empathy, right? And it turns out then they looked at how they were doing in terms of a number of clinical parameters, and the patients who had of high empathy MDs were more likely to have fairly good diabetic control, good LDLs, versus those who had low empathy. So they said that this is a clinical outcome, right? A positive clinical outcome that correlates with physician empathy. Sounds good? Well, it sounds good. But for those of you who aren't familiar with it, this is a scale that was actually developed for medical students I have a number of concerns about the scale, and one is that, if we ask each other in the room what empathy is, we are going to get different answers. Empathy is something like love, like concern, like care. These are culturally mediated terms. And yet, this is something that has been established. It's changed slightly depending on whether it's done for medical students, practicing physicians, but it has been essentially spread throughout the world. So it's done in South Africa, in Korea, in China, throughout Europe, and North America, without really thinking about what it means. So these are preconceived notions. So what this is measuring actually is how well your responses correlate with the definition of the investigators of empathy, right? So I think there's some real issues here. But the other thing that really strikes me is this: in thinking things over, do we really need evidence to justify our treating our patients as human beings? I mean, it sounds like a no-brainer, but this is, we get into this argument all the time in these major conferences. I finally had to stand up and say, there's something wrong here. So look, I'm an endocrinologist. We live by evidence, all right? So I think evidence basis is great. But I think that we have to look at other things. So the one question becomes then, what does it mean to center one's care on the person? So my premise, and this goes back to what's called a first philosophy or first principle. So a first principle is an ethical principle originally developed by Aristotle, or at least he was one of the proponents of this, that said that an ethical statement that is a first principle does not need justification. It is a given. Okay, thou shalt not kill children. Okay, well, it depends. If you're a Republican and believe the healthcare reform, it's going to change matters. But at least for most people, that's true. All right. So the first philosophy, or first principle in medicine, I believe, is that medicine is a social and ethical practice. So this actually goes to a philosophical discussion of self and other. Who is this other person in front of me who has an ailment, who has an affliction, and how can I best understand his or her needs and address them? My thinking along these lines has been really deeply influenced by Emmanuel Levinas, who is a French philosopher of Lithuanian Jewish heritage. Levinas was a contemporary of Jean-Paul Sartre. He was actually raised in France, educated under Edmund Husserl at the University of Freiburg, but was exposed to and became a huge fan of Martin Heidegger, because he went to Freiburg at the same time as Being in Time came out the same year. So he was enthralled by Heidegger. And he finally broke ranks with Heidegger and completely disowned him when Heidegger became a Nazi. Levinas then went back to France, went in the French army, fought for a month, was captured, spent the rest of the war in a prisoner of war camp. Luckily for him, his entire family was wiped out during the Holocaust. So after the war, his whole philosophical product was essentially a response to Heidegger. Okay? Heidegger said in the first part of Being in Time that the major question confronting modern man is the question of being. So Being in Time is a dissection of what being, Dasein, as in human being means. So Levinas said, no, the foundation of being isn't this idea of what being is, but it's actually the relationship with the other and who this other person is, and that relationship is at its basis ethical. So unlike Heidegger, who really believed that we needed to understand ontology, being, the study of being, and epistemology and ethics in terms of this being, this thing, okay, this Dasein, in a totalizing way, Levinas said, no, it's not the totalization that's important, because when we do that, we forget who this other person is. The other person becomes abstract, and then it's easy to gas them, to kill them, right? So he said, no, the role of philosophy is not to create a totalizing system, but is to reveal the uniqueness, the mystery of the other in this ethical bond that we have. So Levinas has a concept called the epiphany of the face, is the call, the insistent ethical demand of the other. Okay, that other is saying, understand me, see me, I have needs, right? But he also says that one can never completely know the other. We can never capture who that other person is. That other person exists in infinity because that identity is always escaping our ability to turn that person into a thing. He says the self and the other are ethically and existentially inextricably linked. Levinas then, since we're talking about the possibilities of care, one of the other really important points between Levinas and Heidegger was Heidegger had this concept of care, or Sorge. And this was care, but it's not care as in I care for another person. It's I'm concerned about somebody. It's almost indifferent, okay, attention paid to this thing or this being or this person. Levinas said, no, in contrast to that sense of care, that concern, there is an inexplicably, inescapably human ethical dimension to care. I care for that person. I use the term radical caring because he extends this care beyond all bounds. He often quotes Dostoevsky's Brothers Karamazov, and he says, each one of us is guilty before everyone and for everything, and I more than all others. Levinas oftentimes will quote this rabbinical saying of tikkun olam, to heal the world. It is my obligation as a human being to seek out injustice and to address injustice and suffering. Okay? So he says, for no other reason than being another human being, you give yourself completely and humbly to the other. This is actually a service, okay? The other is, as he says, on high. To the point of substitution of your life for others. And you can see how the experience of the Holocaust really resonates with the way he approaches philosophy and existence. This is a saying that has absolutely haunted me since I came across it a couple of years ago. He says, the more I am just, the more I am responsible. One is never quits of the other. Le plus que je suis juste, le plus que je suis responsable, l'on n'est jamais quitte de l'autre. I am bound to that other person with every fiber of my being. And the more I rise, the heavier the weight of responsibility for the other person is. So if we look at it in this context, sources of dehumanization kind of boil down to this idea of the hubris of the self, the pride that one has in seeing the other as an object and assuming total knowledge of him or her. Jean-Paul Sartre says in his essay on anti-Semitism that anti-Semitism is defined by the anti-Semite regarding the Jew as thing, as immutable other. Okay? And this is actually the basis for bigotry in many ways, right? We deprive that other person, the otherness, of this infinity, of the ability to make oneself into something else. And we turn that person into a thing. So you can see by my remarks, and I think this is what we were talking about, is that there is a close link between person-centered care and culturally safe care. Okay, there's really no daylight between these two. Because both person-centered care and culturally safe care are illuminated by the same principle, which is justice. We are ethically bound to treat the other person as a human being. So the ultimate goal in all this, I believe the goal of patient-centered care, person-centered care, is to recognize the mystery of the other and to act on this awareness and this obligation. So anyway, that's kind of how we're reframing the idea of person-centered care in a slightly different way. But how do we teach this? So Irina had mentioned that at Michigan I spent 13, 14 years developing a program where we took first-year medical students, during literally their first month medical school, we matched them up with people in the community, and they'd go to the homes of these folks, the pairs of medical students, and just to sit and listen to their stories about illness and its care. Okay, and the whole idea was to to kind of use the power of narrative, use the power of storytelling to open their perspectives up to more humanistic dimensions of medicine. So in many ways, this idea of the power of storytelling, the power of narrative, plays a huge role in, I think, the idea of awakening the other person to the mystery of the other, right? Think about it. I mean, think about your favorite story, your favorite song, your favorite poem, your favorite passage from the Bible or the Torah or the Quran. Those are stories that we use to pass down from one generation to another the meaning of something, right? Oftentimes the meaning of an experience, sometimes a very traumatic experience. So that's how we communicate meaning, through storytelling. There are challenges to this notion, though, and I think this also goes back to some of the problematic issues in terms of teaching communication skills and things like that. So a first-year medical student many years ago came up to me and said, so let me get this straight. You learn communication skills so you can get patients to do what you want, right? So there's a certain manipulative, instrumental motivation behind this, and I think we have to be very careful about how we present it, right? So, like I said, we go and we learn these stories. So these students will go to the homes of people to hear the stories, and they go back to small groups, and we have reflective exercises, including writing and poetry. We even have a lot of art that they do. So what is it that we learn from stories? From the stories that you heard from your grandmother or your grandfather or your parents? What do stories mean to us from a learning point of view? And I would argue that stories, the lessons from stories, actually enter ourselves and come to dwell deep within us. And this is also a concept, the indwelling of love in us is very, very important. And this knowledge enters the tacit knowledge we have of ourselves in the world. So it's buried very deep. And this is one of my objections to something like the Jefferson empathy scale. This actually asks for surface recall, whereas a lot of what you get from understanding how people think about these things is actually not by surface. You have to go deep. You have to figure out what's going on inside. Another notion which is very, very central in terms of this type of learning is a notion that I'd picked up from Piaget called cognitive disequilibrium. So Piaget, as you know, is a constructivist, and he believes that children develop cognitively through different stages, right? Or preceding each increase in the stage is a period of what he calls disequilibrium, where the child encounters something that is unfamiliar. So it may be an unfamiliar experience, an unfamiliar person, unfamiliar idea or feeling. And that child, in struggling to try to understand what that is forced to think of who they are and their own experiences. So that discomfort prompts self-reflection. And by doing so, it opens their cognitive perspective to something greater. This happens in adult learning as well. If you think about what we do, right? We learn through periods of difficulty. So this is seen, it's not just Piaget. I mean, you see it, like Plato has this idea of aporia, or Jack Mezirow talks about disorienting dilemmas. Heidegger talks about the strangeness of being. There are just lots and lots of different people. There's Dalloz talks about the encounters of otherness. But so there are a lot of different people who talk, here's the list. Dewey talks about branch points, for instance. So this is a common concept, but it's the idea that you have to put people outside of a certain level of comfort in order to get them to rethink about these things. That prompts self-reflection. So the other point about this is that the power of narratives, as I said, can drive patient-centered care, but its vehicle is actually dialogue. All right? It's not just the exposure, but it's how we engage and how we reflect actively in a group on these experiences that can help those stories go deep. Okay? So the thing about dialogue, and one of my instructors said this when we studied how the instructors were reacting to the stories that they were hearing from the students, because it turned out it was incredibly transformative for them as well. And one of them said something that I've always remembered. And he said, one of the differences between this and, say, talking about a case is that when you talk about these stories, about the human elements, you have to bring your entire self into the discussion, okay? So that becomes very much a part of that. So who we are, who I am, my background, my perspectives, my ethnicity, my sexual orientation, my socioeconomic upbringing, all of this comes into play in terms of how I engage with other people in these moments of dialogue. So this actually led to something else, which I was thinking about, was, well, dialogue is very unusual, and it's not the same as, say, talking about a case, right? So what's the difference between a discussion and a dialogue? And a friend and I got into this long kind of way of kind of musing on this. So let me give you a scenario. And this, because dialogues and discussions can actually happen among the same group of people with the same topic at the same time. Okay, this happens all the time in medicine, we just don't realize it. So a scenario. So an inpatient ward team considers the differential diagnosis of jaundice, weight loss, and abdominal mass in a 63-year-old woman. Okay? Eventually, their workup reveals an advanced inoperable adenocarcinoma of the pancreas. Imagine what they're doing when they're talking about the differential diagnosis. Okay, they're talking about the physical findings, elements in the history, lab tests, kind of looking at the probabilities. But when they actually have to go and tell this woman that she has inoperable cancer that will lead to her death, most likely within the next 6 to 9 months, if they step back into the room and they talk about what that meant, what they just heard and what they just said and how they felt during that time, it is not exactly a discussion. It changes. The nature of discourse changes. So one way to look at this, between the differences between discussion and dialogue, are in a discussion, the approach is chiefly cognitive. Think about what we're doing when we're doing a differential diagnosis, right? We're sorting things out, we're looking at probabilities. The emphasis is on objectivity, the objective analysis of data that is presented. The authority is preserved. Usually the person with the longest white coat in the room wins the argument because he or she has the most experience, right? Rank is pulled oftentimes in these kind of things. The goal is a solution, either a most probable diagnosis, a management plan, something along those lines, right? It's a ka-ching moment where you get something that everybody's going to act on. Well, let's think about a dialogue now. So this is after they've done all the work, they've broken the news to this person, and they've come back and they're thinking about what just happened. A dialogue is not just cognitive, but it's also affective, and it's also experiential, right? Imagine a third-year student being in the room witnessing this woman who has just been told she's going to die. The emphasis isn't on objectivity, but it's actually on subjective and intersubjective interactions, how we work with that person, how we interacted with each other at that moment. Interestingly, the authority also can shift dramatically sometimes. It can be shared or distributed. So imagine that the third-year clerk in the room, her mother just died 2 years before from metastatic breast cancer. So when she talks about what it is like to hear this news, she is speaking with authority that maybe nobody else in the room has. It's the authority of lived experience. And the goal isn't actually a ka-ching moment, it's not a solution, but it actually is enhanced understanding through opening of new questions and possibilities. It opens things up. A dialogue, you can say, centers things, it closes things down. Discussions, whereas dialogues tend to open it up. Now, it's interesting because the other part is Socratic dialogues. We use this term a lot in medicine. This is a very different type of dialogue, right? A friend of mine said, well, you know, what we're trying to do in this course and what, this is very different than Socratic dialogues, because in Socratic dialogue, usually the teacher knows the answer, right, and asks the question to lead the learners towards the answer. So this is a very different thing. It opens things up. And the teacher isn't necessarily the person in control. So personal reflection and dialogue are the soil from which transformation in perspective and identity arises. We have these conversations, these moments of dialogue, and through them we can change the way we see things and we see ourselves. So again, another term that's thrown around all the time, right? In medical education is the idea of reflection. And reflection often means self-assessment, right? How well am I doing? But reflection actually means a lot more than that. Think about the reflection we have on moral dilemmas, or the reflection we have at the moment that somebody's told that they're dying. Those are different types of reflection, clearly, than just self-assessment. But the trouble is that when we talk about reflection, oftentimes in this context, we oftentimes talk about it where we center it on ourselves. You know, it's how I feel and how I'm a doctor and how I'm really compassionate and stuff. And it's all about me, right? So it becomes this really elaborate form of navel gazing. And it's like, oh, look at me and how I feel. And that's not the point. The point is that we need to take the reflection and we need to turn our gaze out into the world, into the patient, onto the other, right? So how do we do that? And how do we think about reflection not just as a moment of mindfulness and self-awareness and self-fulfillment, but how do we ultimately direct it towards that other person? So how do we facilitate these forms of reflection? And this is another way to put this is, and this is often comes up, right? How do we create space for reflection? How do we do this in the curriculum? How do we do this in learning? This is also something that we ask ourselves ad nauseum. So this friend and I, Tharusha Naidu, who's a psychologist, clinical psychologist from South Africa, were talking about this. And you know, we started thinking about the notion of space. What does space mean? Space for reflection. Is this a geographical space? Is this a room? Is this a location? Is it a time? Is it a space in the curriculum? Is it an activity where we all sit around and say, okay, we're going to reflect, right? So what does this mean? And we came up with 3 elements of what we think that are important in this act of reflection on the human aspects of medicine. And one of them is a place of safety. So people need to come into a room and expose themselves in a very vulnerable way, open themselves up without fear of judgment, okay? Either from the faculty member, from the teacher, or from each other. So in the small groups that I used to run in Michigan, the students spontaneously started calling the Vegas rule. So what's said in this room stays in this room. And it was really interesting because I would rotate among the groups to see how things were going and talk with the students, get feedback from the instructors in terms of the lessons and give them feedback and things. And there were a couple times when I went in the room and the student said, we need you to leave because we cannot talk about what we need to talk about. So I said, fine. And I'd get up and I'd leave. Okay? So thinking about how you construct these moments and construct ideas of safety longitudinally is important. Who are the students with? How long are they with each other? How well do they get to know the instructors, and vice versa? Becomes very important. So there's also an issue of trauma, right? So we just published a paper that came out this month in Academic Medicine called Cutting Close to the Bone, Medical Student Trauma and Institutional Responsibility. Because when we talk about issues of race or ethnicity, bigotry, suffering, death, we expose students, or domestic violence, rape, we expose students to violence. We expose them to trauma, okay? And some of them may already have histories of trauma that we trigger. But we oftentimes tell people just to suck it up, or we just don't ignore it, and we let them go on their way and be traumatized on their own. And we actually need, as institutions, to call ourselves to responsibility in addressing these issues. So, place of safety, an idea of a place apart. What does that mean? So, this is when I was a kid. When I was in high school, we actually lived in Japan and lived in a little apartment that was attached to a house, and the owners of the house was this couple, the retired couple, who were deeply immersed in Japanese aesthetics, and the wife was a tea master. So several times a week we'd go into their house. This was similar to their tea house. And we'd go through tea ceremony. And the tea house is really interesting because, as you can see, it's usually in a garden, and the door is only about 3 feet high. So regardless of who you are, you could be the greatest lord or the lowest peasant, you have to crawl on your hands and knees through a door and leave the outside world behind. So you sit there in a very, very small room on this tatami, this mat, and you listen to the whisking of the tea and the cicadas chirping through the window. And you look at the sunlight on the tatami, and you taste the bitterness of this tea, and it's really, really bitter, right? And the whole idea is to develop this sense of mushin, or no mind. You're fully present in that moment, okay? So this is kind of the Zen part of mindfulness, right? So what I'm not suggesting that we break from rounds and all go do tea ceremony, right? That's not practical. Plus that it's hard to find houses like this. No, but the idea is that we need to take a moment and we need to say, okay, for now, we need to stop. We need to turn off our pagers. We need to, everything but emergencies, and we need to talk about what just happened with this woman, whom we told is not going to be alive to see her grandchildren. Okay. So how do we take that moment? It could be very short. It could be only a few minutes. It could be 5 minutes.
Something we call debriefing or
right.
huddle.
Right. Exactly. But we need to do this more actively, right? The third characteristic is this notion of liminality or transition. This goes back to a guy named Van Gennep, who's a French anthropologist. And he said that all cultures have these everybody has kind of life stages, right? And all cultures have what he calls rite of passages, rite de passage or rite de marche. And it's these rituals that we mark different transitions. So there can be a preliminal stage and the liminal stage of transition, or what he calls the reestablishment phase afterwards, where you develop a new identity. And if we think about it, what's happening in medical education is the different passages and the rites of passages. So we have to be very cognizant of this when we are dealing with this type of reflection, because not only is there change going on in the patients and in the students, there's change going on in ourselves. So we leave this room, we leave this experience thinking in new ways about how we practice. So, one other challenge. How do we assess this type of learning, right? And do we multiple choice exams? Do we do OSCEs, standardized patient tests? There are a lot of different problems here about this type of learning and about these type of interactions. And I think we have to be very, very careful about what we are actually assessing. There's a saying that Martin Heidegger, it came across from Martin Heidegger, his letter on humanism, which is kind of ironic, a couple of years ago. And this is on thinking, but it actually applies to reflection in this type of learning as well. He says, thinking is judged by a standard that does not measure up to it. Such judgment may be compared to the procedure of trying to evaluate the essence and powers of a fish by seeing how long it can live on dry land. In other words, we measure things in ways that are inappropriate for what we're measuring. And I think this is the biggest lesson we need to learn from these type of activities. This paper a couple of years ago that Delise Ware and a bunch of us published called Slow Medical Education, there was a concept that I introduced in our writing on this, which is from Virginia Woolf, called Moments of Being. And Woolf maintained that most of life, you go through life living what she calls the cotton wool of daily existence, kind of mindlessly. And then suddenly, when you're walking along First Street and the sun is like this on a day like this, or when you see a child smile, or you smell something in the air, it triggers something deep inside of you, and it touches something in the core of your being, okay? So moments of being are specific moments in life arising out of the cotton wool of non-being, and they achieve a fundamental importance and existential significance. What I would argue, and I think everybody who has dealt with patients or dealt with students or learners dealing with patients, is we have these moments of being all the time. And they may not be things that we can predict as teachers, or they can predict as learners, but they come up as the interactions occur. And what I'm suggesting we do is we take these moments of being and we use them as opportunities for these moments of dialogue. So I think the type of reflection, the type of teaching that I'm really interested in and what we're trying to implement in Toronto is to actually take these fleeting moments, these dialogical moments, to explore these moments of being on the wards, in the clinics, in the ER, on the OR, in post-op, and to try to understand how we can ask just the right questions to get the kind of dialogue started. So what's the role of the faculty? The role of the faculty is to ask questions, to pose paradoxes, not necessarily to always give answers, to tell stories without endings. Okay, so sometimes I will go to the students and I'll tell them the story that happened to me during residency, and they'll listen because they right? And students love to hear clinical stories, especially the first and second year students. And then I'll stop, and it's usually something around it, a really tough ethical dilemma, and I'll stop, and there's this pregnant pause. They'll say, "What do you do?" And I'll say, "What would you do?" And I'll keep asking them that, and then I'll get up and I'll leave the room, and they get pissed off. Right? They get angry, and they'll run after me and say, no, you got to tell us what you did. That's not the point. The point is to get them to think about it and to really engage, right? And to engage in these kind of dialogues in order to understand how they would approach it. So also to create this sense of community and shared, but not necessarily uniform perspective. So how do you create this sense of community in which we're all engaged? We oftentimes talk about communities of learning, right? Communities of practice. That's another buzzword. I have 2 papers down the line, and this is the one we're going to really dissect, because we do this without thinking about issues of power and privilege and all these other things, these messy things that can enter into the dynamics of these communities. So we talked about how liminality, the sense of transition, plays a huge role in medical education, and how the dialogues do. And I think the relationship between teachers and students play this really important role. Mikhail Bakhtin, who's a literary theorist, talks about dialogical learning, and he uses this term, dialogues on the threshold. He uses, for instance, Dante's Inferno as being an example, where Dante's wandering in the woods, and he runs across the poet Virgil, and Virgil actually takes him by the hand and leads him down into the Inferno, and Dante comes up different, all right? This is what we do as educators, is we are initiating these dialogues on the threshold of change for our learners. And how we do this and how we do it well and thoughtfully is really key. I'd like to finish with this. Hans-Georg Gadamer once said, "In Truth and Method, to reach an understanding in a dialogue is not merely a matter of putting oneself forward and successfully asserting one's own point of view, but being transformed into a communion in which we do not remain what we were." So I think dialogue plays a critically important role in this kind of transformation of perspective that I think is so necessary in developing person-centered approaches in medical education. So I'd like to thank the Institute for inviting me, also some longtime collaborators, Delise Ware, Tharisha Naidu. Al Cooper and Lisa Richardson are the current faculty leads of our patient-centered or person-centered care initiative. Also the Wilson Center and the FM Hill Foundation and the University of Toronto for this work. So thank you very much.